Welcome, everyone. I'm Rich Simon. I'm editor of Psychotherapy Networker, and welcome to this series on meds, myths, and realities. And we've been exploring a range of issues about the impact of psychopharmacology on psychotherapy, and about these two worlds of the world of therapy and this world of medications, which has a huge role in mental health treatment today, and often there hasn't been a dialogue about these connections, how to collaborate with prescribers, and how to make these distinctions between psychological issues, biological issues. So throughout the series, we've been exploring those issues, and today we have someone who really has a foot in each world, a psychiatrist who also is a prescriber of meds and whose practice is primarily a psychotherapy practice, though he does have a med management component to it. And here's somebody who's really integrated these two worlds, and it's my pleasure to introduce Frank Anderson, one of the most youthful-looking psychiatrists I've ever seen. This is not Doogie Howser that you're seeing on the right side of the screen, but Frank who has a long experience as a psychiatrist. Hi, Frank. How are you doing?
I'm doing great. Thanks for having me.
So, you really have identified in your practice and your model ways of sorting out of really, because you're in both worlds, you really can offer some guidance to us about a range of the issues that I think are often unexamined in psychotherapy. So let's if you could, let's go through the way in which, how you organize treatment when someone's coming in and they have symptoms that are so extreme that it really does seem like therapy really needs some assistance from psychopharmacology and determining whether, in fact, that's the case. So let's, if I'm a new patient and I'm coming in and I fit that kind of profile, how does the process begin? What are the first things that you begin to pay attention to so you orient yourself to the client's needs in such a case?
Sure. For me, when I think about the medication piece, I'm really thinking about symptoms, okay? And so what I'm interested in is trying to come up with a list of symptoms, because that's really what medications work on. They treat symptoms. And to be able to differentiate a symptom from a feeling, okay? And that would be I would say the first thing that I'm looking to do when I'm working with a client, is to help them start being curious about this differentiation, because people come in with a lot of preconceived notions about what medications can or can't do. And I like to start out with that clarity around.
So let me just pause you there, because that seems like a really interesting distinction. So what's the difference here? What's the difference between symptoms and feelings, and perhaps you can give us some examples of, at this early stage of therapy, what you're getting at with a client where you're developing that distinction.
Totally, yeah, and that's a question that comes up a lot. When I'll ask somebody, what are you interested in having a medication do for you? Oftentimes you come up with, well, I don't want to feel so sad, I don't want to be so lonely, I'm tired of feeling so much despair. Okay, those are feelings. Those are not symptoms. Okay, when we're looking at a symptom or thinking about a symptom, I'm really thinking about panic. Okay, depression, not sadness. Inability to concentrate, not able to sleep, difficulty focusing. Okay, those are a list of symptoms. So that medications really work on symptoms, not feelings. And to really help somebody right off the bat differentiate that, one of the common things is, medications treat depression, not sadness. Oftentimes when a medication works, people become more sad. And that really confuses them. And I say, now it's time to do the work. The symptoms of sleep trouble, appetite, difficulty, trouble concentrating are gone, and now it's time to do the work, and feelings come up.
So the feelings is the more subjective, the personal meaning aspect
Exactly.
of it. The symptom
Yes.
as a somewhat more objective, more what we might identify from more of a distance of what's distressing to the person. The feelings is a more close-up subjective view. Is that one way to put it?
Yeah, that's a way to put it. And you know, I would also think about it physiologically or biologically.
Mm-hmm.
Symptoms are biologically based and biologically rooted.
Mm-hmm.
Okay, so when you're having a panic attack, your heart's racing, you're feeling anxious, like I'm going to die, I'm going to have a heart attack. That's a physiological response,
Mm-hmm.
which is kind of different than an emotional response.
Okay, that's interesting.
Okay, so this.
Okay, so in a first session, you'll explain that with a client who's coming in. Let's say they're coming in and they're feeling they can't sleep, they're extremely anxious. We can fill out the symptom picture there, and so once you've made this distinction, where do you go of symptoms and feelings?
So we come up with a list of symptoms, okay, and that's what we're going to be tracking through the course of working with the medication. So we come up with this list of symptoms, and that's what, you know, when somebody comes in for a med check or a follow-up visit, we're going to look at that list of symptoms and see, are they gone, are they partially there? So that's what we're going to track, okay?
Mm-hmm.
Once we've kind of come up with this list of symptoms, this is where I think the art and the trickiness comes in, and where I really am hoping that therapists are going to be more involved in this process of differentiating a psychological from a biological issue. Okay.
Okay.
This piece feels really important to me, and I don't think many therapists are doing this. I don't think many psychiatrists are doing this. You know,
No,
psychiatrists.
it seems like really, it's the central issue, and it's interesting that it's so rarely addressed, and people have a kind of ideological position that
Right.
well, meds are bad because you're not dealing with the real issues when you give people meds. So talk more about how you sort this out in a more useful way.
Yeah, so and there is a lot of overlap. Like the common language is the mind-body connection. This is what people can understand, but that's for me what I mean when I say psychological versus biological. And that there are times that it can be both, or you can really tease this out. I'm really upset and depressed because my relationship isn't going very well. Mm-hmm. Okay? How much of that is psychological and needs to be worked on and worked through in the therapeutic environment? Mm-hmm. How much of that then actually becomes a biological issue and that needs to be treated with the medication? And to really be able to tease that out, okay? And when is it purely psychological? People will use a biology, a term like depression when it's a psychological issue that needs to be worked through in a therapeutic environment, versus when this psychological issue does in fact become a biological condition, because it does happen. Okay, and teasing out when that happens and how to differentiate that. Okay.
So talk to us a little bit about that, because that really seems at the heart of what's really at stake here when we're considering psychopharmacological interventions. So what do you do? Can you think of a case? Can you give us a case recently where it was that tricky intersection, and give us the flavor of how you handle that?
You know what I was thinking about is if it's okay, I can give you two different case scenarios. One where biology is the issue that's affecting the psychology, and the other being where psychology is affecting biology. Okay? So the first case would be a client that I'm working with, who I do both therapy and medications with, comes in and she's really struggling. Things aren't really going well. She's stuck, okay, classically stuck in therapy. Happens all the time. So what I do with people when I'm working with them is ask them to just take a moment and go inside and just listen to what's going on. Okay, and this is a piece that I don't think a lot of people do, is go inside. Meditation's really hot right now and very popular. meditate for a minute in my office, basically. Go inside
and what is her presentation? So what do we know about her up to this point?
Okay, so she's been in long-term treatment. She, a lesbian woman in a long-term relationship that recently ended. Okay, and we've been working on that, but also working on other things, her relationships with her kids. But therapy's stuck, and it's not moving, and it's not moving. So where I'm trying to distinguish here, how much of this is about the loss of the relationship, and how much of this is about a biological condition.
And
So,
just focus on this for a little bit. So, and what's happening? She can't sleep. She's anxious. She's agitated. What is it that?
you know what? Interestingly enough, Rich, it's more about therapy's not going anywhere. I don't know. Nothing's working. No, I don't know what I feel. Like there's this kind of deadening.
A deadening.
And a deadening, a numbing, a lack of any movement in the therapy. Okay? And in her life, really. I would say anhedonia if you want to give it a symptom. So I say just go inside for a minute and let's just see if we can get a sense of what's actually up inside. And so, you know, what I do now is I almost have a stopwatch in my office. When people go inside, it lasts about 3 seconds. Okay, boom, boom, boom. They jump right back out. And I say, no, really go inside, okay? I'm going to time you 30 seconds to a minute, okay? And it seems like an eternity for them.
Okay.
But I really want them to go inside and listen to what's up, different aspects of themselves, okay? And when she does that, she's been working with me for a while, she gets this global sense, and the word that she comes up with is plexiglass. She says, it's if there's plexiglass between me and my insides. Okay? She said, I'm like, wow, that's a very vivid image, right? And so I start asking some questions to her about that. Tell me more about this plexiglass. You know, it's really thick. It's not transparent. I can't really get a sense of what's going on inside. So I say, okay, fine. Is this happening across the board? She goes back inside again and she said, yeah, it's all across the board. That's one of my clues that this is biological. Okay? When the whole system is affected, that's a sign for me that there's a biological condition going on. Versus, when I go inside, you know, there's just this part of me that's just so depressed about this relationship. But I'm doing okay at work and doing fine with my kids. That's a part of her psychologically who's depressed versus it's affecting the whole system. Okay, so then I say, well, are you interested in, you know, alleviating this plexiglass? Would you like some help with that? She's like, oh gosh, would I ever? And I say, see if you can see inside if your system also wants some help with that. And she gets, she gets this like, oh my gosh, yes. Like I said, is there any parts of you inside that don't want help with this? She goes back inside again and she says, no. Everybody feels awful about this plexiglass. Say, great. Then I know this is a biological condition. Her system's on board. And then I move into the next phase of what I typically do is say, okay, fine. So now that we know that there's this thing that's affecting your whole system, and we know that your system really wants help with this, here's a way to help it. And then I start moving into the, you know, there are different medications. Here are your different options.
Let's pause there for a moment.
Sure.
So you're influenced by internal family systems, and we'll talk more about how you integrate that with your role as a psychiatrist and a prescriber as well as a psychotherapist. But if you were to talk in a more traditional psychiatric language about this woman, and how would you describe what it is that determines whether she is a candidate for a medication? What are you seeing in a more traditional vocabulary within her that puts you on a certain course?
Well, and maybe I'll reiterate it in a slightly different kind of way, but when I see somebody who's globally affected and it's affecting all of her systems and she has no ability to move, with it in any kind of way, and she is overall wanting help to get rid of this effect, then I feel like we're dealing with something here where medications can be helpful.
And what would so there's an overall effect, so there's a kind of a deadening effect. And what is it? Is this, we call this low-grade depression? We call this, what's the language?
This would be a depression, yeah. I would call this a depression. It's this depression that's kind of blanketed her whole system in a way that doesn't allow her to move in her life in the way that she used to move, doesn't allow her to interact in her relationships with her kids at work. She's kind of deadened, numbed, and in a global kind of way. Yeah, and I could use...
Physiology is so... has been so affected that you don't think just through talk, through the standard interventions, when the physiology is affected in this way, that you need something, you need a kind of assistance as the therapist in that.
Exactly. That's exactly right. And I really believe, and certainly myself as a therapist have experienced this, is that stuckness. That this lack of mobility in the therapy, if you're working with somebody, you know what the flow is like, and you know how they move in and out of working on issues. And it's really common that this stuckness comes in this very pervasive way. And so that is one of my clues that something's going on here. And people, I think, often rack their brains like, what am I doing wrong? What's going on here? And it's not about an inadequate therapist or an inadequate patient. It's about a biological condition that has kind of superseded or overridden the system. And there's a way to kind of correct those chemical imbalances to allow the system to flow freely again.
Okay, so let's give us the count before we move forward with this case.
Sure.
What's the counter example where it's psychological, not biological, would look like?
Yep. Certainly. So this is another example of the opposite effect, really, where where psychology, well, not opposite, I shouldn't say. There's a couple different examples, but this is where psychology affects biology, and it becomes a biological condition. Okay. This is a client who I've been working with for a long time also, who has a pretty horrific trauma history. We've been doing really good work. She wants to cut down from twice a week to once a week. Seems like a reasonable goal. There's this one more piece of work to do on this traumatic event that she had. We're clear about that. We set up this structure and we start doing the work. Her goal is to go down to once a week in the summer so she can have a nice summer off. She's a teacher. Okay? Great. And then all of a sudden things start happening. She starts missing sessions. She starts not paying her bill, which is really unusual for her. She starts gaining weight. She is just not accessible in the way that I know her. After she does finally come in, I say to her, let's look at this. What's going on here? That all of a sudden there has been this change. Okay, let's look at this. Let's see if we can understand this from a psychological perspective. So she does the going inside and just kind of seeing if she can get a sense of what's up, and she really bursts into tears, which was really surprising to me. And she says, I can't do this work. This is too painful. I'm afraid. I'm terrified, and I'm afraid you're going to hate me for that. I say, well, I'm not going to hate you. You know, it's really great to know that. And then as she kind of listens more and checks in, she says, this is just too scary and this is too painful. And then, this is the way I phrase it, this part pushes the biological button. And then she develops, because of the psychological issue, all of these symptoms. She was already on an SSRI. It stopped working. She gained weight. She's having trouble at work. So this psychological issue that she has and this fear of moving forward all of a sudden brought up this condition. And then when we kind of go through that list of symptoms, she's got them all. Trouble sleeping, difficult with appetite. She's got all the symptoms of a major depression, okay, even on an antidepressant.
Okay.
Okay. So this for me is an example, and we do a piece of work around that. And when she listens, she says, I need this medication needs to be changed. It isn't working anymore. I'm really depressed. I can't function. And the roots of it are really the fear of moving forward in this work. Okay.
So you've identified this, and so then is the next step for you, as you've made this as kind of an assessment.
Yeah.
Which direction you want to go therapeutically or psychopharmacologically, and what's, in terms of the way you like to work, what's the next step? And maybe if you can pick up with either of these cases, just for continuity's sake,
sure.
So sense of how you operate.
Well, so, the next step for me would be kind of validating the experience inside. For, this kind of validation. Oh, wow, that makes a lot of sense. Uh-huh. Of course, there's a part of you that is really scared and doesn't want to move forward. That validation piece is really important here, in my view, because it allows the system to be on board with the change around taking this medication. Okay, so there's validating. Yeah, of course, and that the person really feels like you get it. Okay, of course it makes sense. There's no judgment here. You're not wrong or bad for being afraid of moving forward and then having this biological condition. So there's this validation of the experience. Mm-hmm. Or, for example, of course you don't want to do this work, and certainly you don't want to take medications. It's taking a foreign chemical into your body. That makes a lot of sense to me. Uh-huh. Whatever the fear is or the concern is, to validate that.
Yep.
Okay. Second piece is really about educating somebody with an option. I really don't make decisions around medications, and this is a lot of unlearning of all of my medical training, uh-huh. which is you are the expert, you know what's best for people. I do the total opposite. I say, I'll educate, you decide. So I say, here are the list of medications, here are the symptoms that we've identified, here are some options of medications that can help with these symptoms. What would you like to do? And I really have it be the client's choice, so that they are making this decision. Nobody is doing this to them, or nobody is telling them what to do. It's their choice. There's no compliance issues in that mindset, because they're not doing this for me. They're making this decision themselves. So I would educate somebody about their options, and that takes a while, to educate them about their options, and then they really pick. And sometimes I'll have people say, I can't decide. You pick for me, and I think I'm not going to do that. Really, you just think about it, and here's your choices, and I really kind of allow it to be theirs, not mine. Then, if I kind of continue through that process, and they'll pick something, I'll kind of set up education around side effects so that people are really informed about what to expect. Okay. And I also, in that education process, I'm really going to ask the client to listen to their system every step of the way. Because at some point, some aspect of them may really get frustrated with this, may not like a side effect, something may pop up that will really stop the process from working. And I really say, we really need to stay in communication with your system every step of the way. Okay, and a common example would be sleep. I can move into that. So that somebody takes a medication, and then all of a sudden they have trouble sleeping, which may be a side effect of the medication. Okay, and if they're not aware of that, their system can get all dysregulated around that side effect. And that we really need to listen to concerns that come up around any side effect. I work with trauma a lot. It's not popular to take substances into your body in a way unless you feel totally in control of that, or unless, if something comes up, it is going to be addressed when it comes up. So that's an important piece for me around this ongoing communication, ongoing dialogue, and that the client will continue to check in and listen if something comes up in this process.
So let's underline this, because this seems like a very significant part of what you're doing, and certainly reflects your interest in internal parts. So what you're saying, because often it seems to me these medication and therapy, they exist in separate worlds. The communication between psychiatrist and therapist is often, shall we say, imperfect. It's on a separate track. So part of what you're orienting your clients or your patients towards is a certain kind of internal awareness that's informed by your notion about parts and how parts speak. So how do you educate your clients to that, or how do you, and maybe this is intuitive, or maybe this is more, talk to us about this.
Sure. You know what? It's really interesting because it's so easy for everyone. It's just that nobody really does it, and people get really surprised. You do not have to be an internal family systems expert to do this work. I say, just take a minute and go inside and see if you notice any sensations, if you notice any feelings, if you notice any thoughts. And it really is that simple. Okay, something pops into my head as I say that. Somebody does that, doesn't even know what internal family systems is at all. Yeah. Say, just go inside and see what you're noticing. She's like, I hate this medication. It makes me fat. Okay, there you have it. Like, that did not take very long. Okay, this is not voodoo or magic. It's about people listening to their sensations. People know what goes on in their body. That if they just listen, okay, and there's so much information around that. Medications affect their body, okay. I don't like this weight gain. It makes me feel nauseous, and I have a feeling about that. That's all we're talking about. Like, this is really simple, but I just feel like people don't do that, whether it's the therapist or the prescriber. What are you noticing inside? And really, a feeling, a thought, or a sensation comes up. And that's what we work with. And then the system feels like it's being listened to and responded to, and then there's more cooperation and collaboration around the medication process.
So when you say that's what we work with, talk to us a bit more about that. So that happens, or someone is having what you described earlier.
Yes.
I'm having trouble sleeping.
That's right.
And I don't know what to make of it. I don't know, should I get off this medication?
That's
or
right.
I don't know what to do, Doc. How is, I'm sure that comes up all the time.
That's right.
So just give us a little bit of the flavor of how you work with that sort of thing.
Certainly. And you know what, this is another way of kind of working with this is everybody, many people are in relationships of any different kind. There is this negotiation that goes on. Just like there's a negotiation in any relationship that we're in, you negotiate needs, right? There is this internal negotiation. Sleep would be a classic example. Somebody says, you know, I'm having trouble with this medication because I think it's affecting my sleep. Say, okay, fine, let's work on that. Okay. And we want to get this kind of collaboration or agreement. What feels reasonable here? What's the bottom line? Okay. You know, like if it takes you an hour to get to sleep, does that feel okay? And is it worth continuing with this medication? Because, you know, my sense is that this symptom will resolve. Okay. And so that would be, is it, you know, what's your bottom line here where this is really not okay? I can't tolerate this anymore and I need to make a change or I need to get off. Okay. So it's that kind of negotiation. And, you know, it's really interesting. A client of mine around wanting to taper. This is a clinical case that comes up. He wanted to taper his medications. He wanted to get off of it. And I said, sure, that sounds reasonable. Let's set up a plan for that. And all of a sudden he's like, well, something's going on. My shoulders are getting really tight here. And I said, well, let's just pay attention to that. And so when he starts listening to that, he's like, wow, there's a lot going on in my life right now. He's like, I'm getting a new boss at work. My wife is really stressed out. Maybe I shouldn't do this. Is that what this is telling me? And I say, well, I don't know. Let's just kind of pay attention here. And so then we start this negotiation process with him in this tightness in his shoulders. And, you know, I say, well, do you want to move really slowly and see if it's okay? And he says, well, I don't know. I said, well, just just let's mention that and see what happens in your body. And he kind of is like, I guess that seems okay, you know. What if we, you know, move down, you know, 25 milligrams a month? Let's go really, really slow, okay? And if this feels okay with your system, let's go with that. But if it doesn't feel okay, you may get some of that tightness back in your shoulders, and you need to listen to that, okay? And then he's like, oh, okay, so I guess if I listen to my body, I can still taper the medication as long as I go really, really slow and respond if my body doesn't like it. And I say, exactly. So that's the kind of negotiation I'm talking about, is just listening to what's going on inside as we're moving forward. So it wasn't like my shoulders are getting tight, okay, fine, we can't taper this medication. It's more like, let's really pay attention to what's going on inside every step of the way through this process, and if something comes up, we're going to tend to it.
Yep.
I don't think psychiatrists have the time to do this in this 15-minute, once-a-month venue. Okay, and this is, for me, where therapists are tremendously resourceful in negotiating this process while it's happening.
Yeah, and I wonder how widely the med issue, because the therapist is the person who's having more contact, is at the front lines, is noticing from week to week what's going on. So in terms of how the therapist who you talk to, and incorporating just what you're saying, what's your experience with that? Is there, do therapists have some resistance to moving into this, being prescribers, or feeling like maybe this is not my role to talk with people? I don't understand the effects of meds. What's your experience of how that might translate into people incorporating this into their therapeutic practice?
Totally. This is one of my quests, let me tell you, because really nobody's doing it. The psychiatrists are not doing this, okay? And either are the therapists.
Therapists aren't doing it either, you're also saying.
Yeah, that's what I'm saying. The therapists are like, oh, I think you need meds. Call this person. See you later. That's it. There's no communication. There's no, what do you want me to do up front so that we can make this easier and more efficient? You know, the other piece that I think about is being both a therapist and, along this realm, is being a therapist and a prescriber, is that there's this sense of shame. Like, there's this, I don't want to deal with this because maybe I failed, or I don't know anything about meds. How could I possibly talk about this?
Yeah.
But if you've listened to what I'm talking about, I'm not talking about what is the neurotransmitter effect, what's the serotonin effect here at all. I'm saying, you know what I mean? Yep. So the fear that therapists have around working with this medication intersection of psychology and biology is a fear. Because we're saying, listen to the body, work with the patient through the process, hear what they're responding to positively or negatively. That's not neurotransmitters and serotonin levels.
Yeah.
Okay? Yeah. That's about staying in the process, and this is another piece which we may or may not get into now, and be aware of the therapist's parts of themselves that get freaked out, nervous, or activated when they're having to deal with this intersection of prescribing and medications. Because, a lot of therapists have feelings about medications. Like, I didn't become a psychiatrist. I don't really believe in medications. I want to do therapy. I think that's really better. Or I have no idea what that is. I'm freaked out by them. Whatever their issues are, to really be aware of that so that those aspects of the prescriber don't get in the way of them just hanging out with their clients to really learn more and to be with them through the process. A lot of therapists feel like they've failed if they have to send somebody to a psychiatrist. I've done something wrong. Look, I'm not a good therapist. What I'm offering isn't good enough. They need a med. So to work within the prescriber themselves around, maybe this is not about my inadequacy. Maybe there is something going on biologically. Let's see if we can sort that out and maybe correct that imbalance. Mm-hmm. Okay, so does that make sense?
So that seems the crucial issue here. So it's the therapist as a common attitude is, this is beyond my expertise. This is what psychiatrists do. This maybe I'm practicing outside my competency.
Right.
If I have any real discussion about meds is one element. The other element being what you're saying earlier, the anti-med bias.
Right.
That is in the world, the circles in which I am familiar with.
Yes.
Attitude.
That's right.
And so so you, if I'm hearing you, what you're saying is with some relatively simple practices,
yes,
you can begin to have an integration in your work where you don't need to be intimidated by this or blinded by your own ideology. And the meds can be the relationship between your client and the meds, if they're taking it, can be really a central part of the psychotherapy.
Totally. That's exactly right. And when it makes sense, if you're having a dialogue with your client about this, then you can use it as part of the therapy. When do we need this? When don't we need this? Okay, because that's a discussion. Because meds are not start once and then that's it. It as a therapist, and EMDR is one of the modalities I use too. I can integrate EMDR into my psychotherapy practice, and I can integrate psychopharmacology into my these are tools.
Yeah.
Okay. A lot of therapists have a lot of different tools, and you can integrate them.
So here's the common one. I think probably the most common issue, and I'd be very curious about how you handle this. So, going back to where we described, we began this. We identify symptoms. You make your distinctions of symptoms and feelings. You educate rather than dictate about certain medication possibilities. The client begins to take the meds, and as we all know, in a very large proportion of cases, they, quote, don't work immediately.
Yes, that's right.
So the person's coming in, they're in distress, they're anxious, they're depressed, they're not sleeping, the world life is hard for them, and they're coming into your office. And what's the role then? How does it that in this integrated approach that you're describing, what's the process for you at that early stage of treatment and working with clients to help them find whatever the relief is going to be, whatever's going to work for them?
Say that again. I'm not quite sure.
So it's not working. I'm trying the med.
Gotcha.
So
Great.
What do we do now until we just sit here and wait? And maybe,
that's right.
Maybe in week 3 it'll kick in, or week 4. So that seems like the very tricky period.
It's a great question.
Intervention.
It's a great question. So, and it's the same principles. Okay, I do a lot of consultations. People send people for consultations, and I can't tell you, nothing works for me. I've tried everything. Meds don't work. I mean, I get that stuff all the time. And there is a way that, and I do think therapists need to be educated a little bit. Like, it can take 3 or 4 weeks for a medication to work. Fine. So let's wait that 3 or 4 weeks. But when things all of a sudden stop working, or things never worked, there's blocking, these medications aren't working, that's where I'm going to say go back and check out what's going on inside. Okay? And a great example I have, first let me say this piece, in my view, okay, and this is not written up anywhere that I'm aware of, a psychological issue can block medication effects. I see it all the time. I really do. When I referred to the hypervigilance around somebody who doesn't want to sleep, and nobody is negotiating with that aspect of that person, it blocks everything. Okay, and people are throwing they're throwing everything at this person. Nothing works. Really? Has anybody ever asked that there might be a part of you that doesn't want to sleep, and how do we negotiate with that? That doesn't happen. Okay, and so in my view, medications can be blocked if those aspects are not tended to. Okay, a classic example, I can give you a clinical example with a client who comes in, and I'm only doing medications with this person, so they're seeing somebody else for therapy. Meds aren't working, up the dose. Meds aren't working, we go through the whole thing, and then I say, okay, hold on, let's just take a time out here. Like, what's going on? Let's see if we can learn a little bit more about your system to hear if there's something up. Are there any parts of you that don't want to take these medications? I don't know. Nobody's ever asked, is what I hear. I said, well, let's just take a minute and see. Okay, and then so she does this kind of, brief little meditation in my office, and she says, and this is interesting because this is just her assumption, my little girl, the little girl part of me, and my little girl doesn't, how did she say it? My little girl, it's got to be my little girl. I says, well, okay, let's see. Does your little girl not want to be depressed? What's going on here? And so she does this, she goes, my little girl doesn't even know what depression is. She's like, that. I'm like, okay, so that ain't it. She doesn't even know the word, right? Whatever, fine. She goes, you don't even know depression. I say, okay, fine. What else is going on here? So then she kind of just listens inside again, and she gets this whole feeling, okay, and she kind of starts tearing up, and she says, oh, wow. She says, this depression serves a function for me. And this is new information for her. I'm like, what do you mean? Let's hear more about that. She says, the last time I went out, she's a single woman, met somebody, I got close, I really got hurt, and I vowed I would never let them happen again. I would never be hurt again. So I'm really getting this sense that this depression is functional for me. It's protecting me from ever getting hurt again.
Yeah. Okay?
That's the psychological piece that's interfering and intersecting with this medication not working. Okay? This part of her says, we're not getting hurt again. No way. Okay? And I'm not going to, you throw anything at me, I don't care, it ain't going to work. And that really does happen in my view, honestly. Yeah. So then we do this whole piece of work with this aspect of her that is really terrified to go out there and meet somebody. Okay? And that validation of that is a huge relief for her system. Okay? She said, oh my God, I didn't realize that was at play here. I had no idea that that's what was going on here. So I instruct her to go back to her therapist and work on this, because I'm not doing the therapy, I'm doing the med piece here, and to really look at those fears around meeting somebody, okay? And I say, when you have a better handle on that, come back to me and let's see if we can navigate these medications up or down or change them after you get a better sense of this system that's working for you. She says, okay, fine. She comes back a month later, and then there's a different kind of negotiation around these meds, okay? And she says, I think it's okay to increase them. Let's just increase it. And she was on Lexapro, and she went from 5 milligrams to 10 milligrams or something like that, or I don't even remember, to tell you the truth. And sure enough, a month later, she's feeling much better, okay? That in that situation, there was this psychological aspect of her that was really blocking any medications that were being thrown at her. She didn't know that. Nobody asked. When I had her just go listen to what's going on inside of her, she gets this awareness. Her whole system works through something, and then the medications really work. And they do work. Like, this sounds voodoo, but it's really true. She comes back, and all that list of symptoms is better now. Okay, and that is really a perfect example of the kind of work that I'm doing that I really believe therapists can do to figure out.
Standing back from this,
yes,
then, and this sounds like something that is very useful information for therapists, at least to consider in their role with clients, the many clients who are taking meds.
Yes,
that people to consider whether this model might be something they want to adopt. What seemed to be, if you were to categorize the common psychological blocks to medications working, when you go through this process, what you discover. Are there two or three? So part of it is if in fact the medication works and I go out there and I begin to, I can get hurt. I can, if I'm behaving in a more, if I have a more normal life, I'm really in jeopardy.
Yeah.
Is a big one, I would think. Are there others that stand out for you?
The body piece is a big one, too. There's a lot of fears around what is this substance going to do to my body? How is this going to alter me? You know, when I'm taking this, you know, it's so interesting, and I love this. Like, I don't want to take a substance, as this is a chronic pot smoker who's drinking, you know, 4 or 5 bottles of wine a night. And it's like, oh, isn't that interesting? You don't, you know, so there is this perception that is very common. That's a pill. I don't want to take that. Okay,
right.
So there's a lot of fears around the body and around these substances, and I think education alleviates a lot of those fears. Here's what it is, and it works on serotonin and this kind of thing. So that body fear is a big one.
Okay.
That I deal with a lot.
Right. The foreign substance inside me. Yep.
The foreign substance inside me, and then that power differential that ensues around that. And some authority figure is going to tell me what's best for me and what my body needs. So that's where I get into this. Look, I educate, you decide, because the power differential is a big one for a lot of people. You know, that when they're going to someone who they don't know, and they're going to come out with a pill that's a foreign substance, you know what I mean? That whole dealing with those power differentials, and this person's going to tell, you know, the fear around this authority telling me what's best for me, and I'm not going to have a choice. You know, many clients, I have to do what the doctor says. Mm-hmm. Like, what? Where's that come from? Well, they're this authority. You know, so this dealing with that power differential is also a big blocker.
Makes sense.
For me in working with clients around meds. Mm-hmm. And then really the fear of losing some of these symptoms that are very functional. The sleep thing is very common. You know, get me to sleep, knock me out, give me whatever it takes. Like, hey, there's a lot of good reasons why your system doesn't want to sleep. And you really need to listen to that. Sleep's a very common one. Yeah. You know, same with sex, you know, the sexual side effects of meds. And the weight gain, those are common, and they need to be negotiated. If you don't want to gain more than 5 pounds, you need to make a commitment that you're going to stop this medicine if you gain more than 5 pounds. You know, sort of really working with those side effects that are real, that people need to be educated about, but also really feel that they have choice versus, oh my God, the psychiatrist says I need to take this, and I'm gaining 15 pounds, and I feel awful. That's where compliance comes in. That becomes a compliance issue because they're not making the decision, and they haven't been empowered to say, I'm not going to take this if I'm going to gain 10 pounds.
So what's very interesting about how you're laying this out is the more we talk about it, the more it seems to me that there's a quality of mystification about psychopharmacology within the therapy community.
Yeah,
that this isn't my province. This isn't my expertise.
That's right. Yeah.
And what you're saying with just applying some of the sensibility, the skill one has in working with anything else in psychotherapy, it can be applied to medication. Totally. In this very helpful way.
Yes, that's right. Yeah. That's right. And the other piece I'll say about that is the demystification. What is the big component of the demystification is communication and collaboration. Okay? And I would say this to the therapist with the prescriber, as well as the therapist with a client, and the client with their system. Mm-hmm. Okay, do you know how shocked a psychiatrist or prescriber would be if a therapist called them up and said, I just wanted to keep you attuned to what's going on with the client. The meds are working really well, and they had this one side effect. Like if there was communication, it's like a prescriber would be shocked to get a call like that from a therapist. Oh my goodness. You know, it's like, you do your thing, I'll do my thing, see you later. You know, and the same thing, I make a point, I really try to call every therapist after I've worked with a client. Here's what's going on, here's what we're thinking. So that communication between the prescriber and the therapist, and most of what we've been talking about today is really that communication between the client and their system, but also, of course, between the therapists. It's just having those discussions. What's up? What's working? What doesn't work? What do we need to do? That ongoing communication and collaboration.
And so are there certain, I was surprised the other day, I was talking to a psychiatrist who was saying that one of the difficulties he has on his end of the collaborative relationship, I wonder if this is in your experience, therapists having very set ideas about which meds work and which don't, and that it becomes a kind of a tug of war with the psychiatric prescriber. Is that something you encounter?
So a little bit, not really. So this is a great point for me, because in fact, I think psychiatrists need to listen a little bit more if you want to know the truth. Sure. Because therapists spend a lot of time with these clients and they know them really well.
Yeah,
okay?
They're following them more closely.
Yeah, and so, but also, and this is where I get into this, if a therapist calls me and says, hey, I'm thinking that I've heard a lot about Abilify lately for dissociation. Do you think this might be good for this person? I really welcome that. You know what I mean? I really do. And I feel like, well, let's have a dialogue. I educate, you decide, not how dare you tell me what to prescribe. It's a dialogue. It's like, oh, tell me why you think Abilify. Well, I saw it on TV. Well, okay, maybe that's not the best reason. But no, you know what I mean? But to have that dialogue about it, tell me why you think this. Because therapists do sit with a lot of clients who are on medications, and they actually do know a whole lot more than I think prescribers believe.
Yeah.
So that's my view, honestly, as a prescriber, be a little bit more open to the suggestion. Yeah. Would really be, and that's being both a therapist and a prescriber.
So over the stretch of the last, the SSRIs came on the scene. What now? But we've had about 25 years.
Yep.
That emerged, and that became. Where do you stand? So there's so much controversy about the effectiveness of SSRIs. We've had a discussion in this series already about that, about so much bogus research, the commerce of the scandalous corruption of research because so much big money is involved. Where do you come out on the studies that seem to call into question impact of so many of different kinds of meds, and particularly the SSRIs?
So I have a fairly long history of kind of, as I said earlier, being involved in the trauma world, doing trauma work, and knowing a fair amount about the neurobiology of trauma. And I really tend to not be involved in any brand names in this kind of way. But if you look basically at a nerve cell, nerves communicate via neurotransmitters. And there are very few neurotransmitters. There's serotonin, there's norepinephrine, there's dopamine, there's GABA, and so in a very basic way for me, I kind of stay out of all of that, honestly, that if your serotonin's low, there are a number of different ways to raise your serotonin. And SSRIs are only one of those ways, okay? Mm-hmm. So I'm very kind of basic in my belief that nerve cells need to communicate with each other. When we reestablish that balance, the system works smoother. Neurogenesis and neuroplasticity can occur, and the system works better. So I actually work with a company that now measures neurotransmitter levels, okay, through urine and through saliva, and they have a whole bunch of different ways of raising serotonin. For example, 5-HTP is something that you can buy at a health food store that's a precursor to serotonin production. So for me, it's not really that much about an SSRI, good or bad. It's about, let's look at these levels and see if they need to be corrected. And I think they're overused, and I think they're underused. I think there's this middle ground here just like there was with ADD, and everybody was kind of, everybody and their brother had ADD, of course, and, I think bipolar disorder is kind of in that category right now. Everybody's got bipolar disorder. So I think there's this middle ground around this, and I tend to be more moderate around, let's be basic and simplistic and look at the levels and see if we need to correct them.
And we do have reliable ways of assessing neurotransmitters, because it seems to me that would be an area of controversy as well. No?
It totally is. Yeah, it is. And I have people sign a form when they do this now in my office saying, this is not traditional medicine. I want you to know that. So that there are a couple companies that do measure neurotransmitter levels. Mm-hmm. They're measuring the unbound level in the system, making an assumption that it correlates with what's going on in the brain. Mm-hmm. In my clinical experience, it correlates very well. But it's just another added piece of information, honestly, that somebody can choose to utilize or not. They don't have to use traditional medicines. They don't have to use the products that these companies have. But for me, and I do know, or I believe that traditional medicine is working on this technology also. Is to be able to measure this stuff instead of it being such guesswork, But I think it's a useful tool, and it's a tool.
So we have, as we know, and again, this is another issue that we've explored in this series about complementary medicine and non-psychopharmacological interventions to deal with the kinds of symptoms we've been talking about so far. How do you determine, in working with a given client, of the various ways we can influence the brain, and what's the difference between getting them to go to the gym 4 or 5 times a week when they have their depression as opposed to the SSRI? What goes into your decision making about how there's certain ways we can, when you're educating
that's
clients,
exactly right. You're right.
Entirely neutral process.
That's what I do. But no, I don't determine it. You're exactly right. That is what I do. And I quote, when I do, some of my workshops, I quote the Zoloft exercise study. I love that study. Zoloft is 47% is effective for depression. Exercise was 42% effective for depression. I love that. I say, okay, so here are your choices. Mm-hmm. Okay, you can do non-traditional meds. Here are some of the options. You can measure your neurotransmitters. You could do exercise and yoga, meditation, acupuncture. This is why I don't get too hung up on the drug companies, because for me, it's one in a toolbox of things to utilize. Yeah. So I do offer people a wide range. And I guess this is part of being a therapist and learning all these different modalities. It's like, who's to say anybody has the corner on any of these markets? And I really do. I feel it's my job to keep educated myself and then to pass that education on to the client. I mean, certainly people walk out of my office without a prescription. Mm-hmm. That is not uncommon, because they've gotten this education and they say, I don't want to take a med. I say, okay, fine. That's totally fine. So it's not my decision.
So in that education process, is there something that you have learned in maybe the more recent installment of your career and your practice of the last 5 or 10 years that has been a surprise to you? That has something that's emerged in the range of treatment options or in med options that that have impressed you?
A couple things. So I'll speak a little bit traditionally, but I'm more excited about the non-traditional piece that I'll talk about in a second. But traditionally, what's been really valuable for me, and this isn't working in trauma, is the low-dose atypical neuroleptics in treating dissociation. Okay, and there's not a lot of literature, there's not a lot of studies on this, because these low-dose antipsychotic medications are used for bipolar disorder or schizophrenia. But, for example, in my working with trauma and in a very often hypervigilant physiological system, okay, these patients, 2 milligrams of Prozac gets them all wired up because their systems are hypervigilant. That very low doses of these atypical neuroleptics are really valuable and helpful for dissociation, quieting down all the chatter, decreasing the dissociative episodes. And I'm talking really low doses. I work with compounding pharmacies, for example, that will make 2 milligrams of Seroquel for me, for the client. Okay, so the very low doses really can do a pretty significant improvement in dissociative symptoms. So that's one piece that I don't know that everybody knows that, and I really utilize that a lot. The second piece in regards to, and this is again trauma related, when I'm working with these neurotransmitter companies, they're measuring cortisol levels, and they have products that can reset cortisol receptors. They're working on the HPA axis, which is the hypothalamic pituitary adrenal axis. And they have products that can reset receptors, cortisol receptors. And I've done this for for about 4 years now. And that's been pretty remarkable because we don't have any traditional meds that work with cortisol, which is one of our main stress chemicals.
What's the significance of that?
Because when somebody has PTSD or dissociation and you're throwing SSRIs and antidepressants at them when their cortisol system is dysregulated, it's not working. That's one of the reasons why these meds aren't working, because their cortisol receptors are out of whack, not their serotonin or norepinephrine levels. So to be able to reset...
You're targeting the wrong system often.
Targeting the wrong system. That's another reason I really believe we will learn more about that, because we have very few choices in regards to meds and neurotransmitters, but oftentimes they're probably not working because we're targeting the wrong system. Exactly.
All right. Well, we're just... our time is just about up.
Okay.
And so just a couple of things here as we draw our visit here to a conclusion. Number one is Frank has offered us a whole range of very, from the viewpoint of a psychotherapist, I think, highly empowering ideas about our role with meds. And it may be that you have responses to that and questions, and maybe you're connecting some dots listening to this conversation. So let's continue that conversation. You'll see on your screen an invitation to contribute to our comment board. Please feel free to do that. Frank clearly is an engaging fellow and has agreed to at least to look at the comment board. You may possibly get a response from him. He's a busy guy, but if it's an interesting question or observation, perhaps you'll hear from him. But in any case, it'll be helpful for all of us to hear what our responses are to this conversation and the perspective that Frank has been presenting. And Frank, if people are more interested in your work and things that you've written and training opportunities, how do they follow up on this conversation?
Sure. I mean, I guess I can. Giving my email. Okay. Yeah, I'll give my email. And I just published a chapter in a book that just got released in March, which is I think it's Internal Family Systems Therapy, New Dimensions, and it is a chapter on this integration of psychotherapy and psychopharmacology. So that's one resource.
Who's the publisher of the book?
The publisher is Routledge. Okay.
Right.
I think it's on Amazon and through Routledge. You can get this book. My email is fgandersonmd@gmail.com. Okay. So you can certainly email me. And, I do a number of workshops and things like this through various venues. I have not gotten a website yet. I've been too busy to do that, and I haven't. Yeah, I'm not quite there yet, but that is to come at some point.
Okay. Well, when the avalanche of response comes to your appearance here on the Networker show, maybe that will be motivation for you to put up your website. What an interesting conversation. How demystifying, how empowering for psychotherapists. Thank you so much, Frank.
You're welcome.
That's it for now. See you again next time. Bye-bye.